Good morning, and we are now ready to start our first New York Valve Symposium with the first case. We had to wait for Dr. Sharma to arrive in his Rolls Royce, and he has made it here.
Okay.
So we
We've
can
had
show
some
the
nice
slides for the
lectures.
first
Maybe
case.
wonderful.
The operators are, you see that, George Dangus, myself.
Okay, everybody
Arthur
show
Khan,
hello when the
we have
name starts.
Gilbert Tang,
Wow, that's a lot
and
of
course we have
operators for
Samir
just the
Sharma,
valve.
and then we have Lirakis, Tamatis Lirakis, who will be the echo, and Benjamin Salter, who is our anesthesiologist.
Okay, excellent. Can we
No,
go back
previous
one
slide,
more
previous
slide?
slide.
One more slide back, thank
Yeah.
you.
Yeah.
Just leave the slide up so we can read it well.
So while you're getting ready, yeah.
Okay.
Okay, this is a 80-year-old male. If you see here, who has symptomatic aortic stenosis, history of multiple prior PCIs, prior CVA also, and the medications you see as documented there. So we can just show the echocardiogram now.
So he's had a prior intracranial hemorrhage, which I think is going to be interesting for us to talk about what to do afterwards, because he does have atrial fibrillation.
Yeah, just to clarify that the CVA is very remote.
Yeah.
There's minimal residual, and the patient had a recent syncope in addition to the chronic status just recently. I went careful neuro workup for possible seizure, but turns out that the aortic stenosis syncope was more important.
Okay.
And the AFib. Yeah. Okay. The live. We can show the live echo.
Cannot.
So,
Yeah.
Okay.
Yeah.
Oh,
Yep.
Tolerakis.
Okay.
Yes, so the echo shows the ejection fraction is about 45%.
They can't hear him now.
Severe
can hear
aortic
now.
stenosis, no evidence of significant aortic regurgitation, minimal mitral regurgitation.
Okay.
And as you can see, the gradients, the peak velocity was 2.3
Yeah.
with a peak gradient of 22 and mean of 12. This patient is a low flow aortic stenosis patient who underwent low dose dobutamine, and the velocity actually increased from 2.3 to about 4.1. So we're talking about severe aortic stenosis, and actually also he was able with 20 mics to achieve a target heart rate that was negative for ischemia by this low dose dobutamine. So we proved that he had severe aortic stenosis, contractile reserve, and no ischemia by the low dose DSE.
Yeah. Actually, that's interesting. I showed in the Topaz trial, they actually had the cases divided based on the contractile reserve and no contractile reserve. 40% has no contractile reserve. The outcome actually was similar, no different. But anyway, keep going. Slides now.
No, but I think this is a very interesting
next
case.
slide.
It's a low flow.
Next.
Low, the EF
gradient
is not
gas.
completely normal, and I think it's interesting you did, and there was some coronary disease that you're now really focusing on the aortic valve based on the echo. So I think, and the
Gilbert will talk
dobutamine.
about the CTA now.
Okay.
Gilbert.
Yeah, so the CT, you can see the annulus is a mean average around 27 millimeters. Valve area is 560 millimeter square area of a perimeter on 85. There's a little bit of horizontal root. We can show that on the aortogram shortly. Next slide. In fact, the LVOT is a little bit on the larger side. You can see here on the measurements, the sinus is certainly very generous. We can see on the aortogram shortly also the leaflets extended from the base actually is quite calcified. Left main is around 10 or so, but the sinus height on that side is around 22. So overall, relatively generous root. You can see here we typically draw a yellow box just to show kind of optimal positioning of a SAPIEN 3 here, just to see any risk of coronary obstruction or any kind of issues. Next slide. Next slide, please. So access is, again, you can see relatively benign. We choose to have the left side for access. No major calcification on the vessels. Next slide. So this is what we do routinely now that the Sentinel device is approved for cerebral embolic protection. We actually look at the arch anatomy on CT reconstruction. You can see here, the left carotid you can see is actually quite tortuous, but I think the overall the right subclavian nomen are relatively straight, and so we decide to also perform Sentinel protection here. Next slide.
Okay, we're good.
So overall,
We're
I think
gonna
this will be a
take
good
on
panel
with the pigtail
discussion.
instead.
Certainly is with the 26S3, it's a bit on the undersized side because the area is on 560, whereas it's a bit more oversized for 29 SAPIEN 3. In this case, we actually plan to do a 26S3 and add 2 cc's to the balloon to expand the valve to minimize the perivalvular leak rather than a 29 SAPIEN 3. Be interested to hear what the panel wants to talk about.
Yeah, so this is really interesting
Next
because
slide.
based
Yeah,
on your
next slide.
route,
Yeah, no,
you
we'll come
might
to
have
that point.
chosen
Yeah,
a 29.
yeah.
So let's go through so let us just have a little bit of a
Yeah.
time so that we can have a discussion, Dr. Sharma. Dr. Colombo, Dr. Grube,
No, but
is
let's
that the
start
size
case.
of
No,
the...
but no, discussion. No, remember?
Yeah,
Let's start the case
I
and
think,
then we'll
I
discussion.
think why don't we put
Yeah.
the team is ready, so
Yeah.
why don't we go ahead
Yeah.
and
And
do
then
the
we'll,
implant,
during that have a discussion. Yeah.
and then
yeah,
we can
yeah,
actually look at some of the angios that were already made. Just so
That's
that
right. We just crossed the valve
We can-
and we're going with the pigtail now.
once we advance the pigtail, and then we'll show some angiograms.
Right.
to
Yeah.
illustrate
Yeah,
the point.
so
Okay,
while
good.
you're
Okay,
doing
George,
that,
will you show
while you're doing that, this is fine. So,
Georgia, aortogram. Yeah.
so
Show
just...
the aortogram
Yeah,
now.
I'll show
Yeah.
you.
Show the sentinel actually.
No, that's sort of
No,
aortogram.
sentinel
So
has
this
been
is the
done.
aortogram you guys can see. All right. Yeah. So you
Yep.
can see, sir, there's certainly coronary artery disease that was shown in the history. There's calcium at the base of the leaflets extending to the leaflets
Always
itself.
exchange.
We typically put the pigtail in the middle of the right coronary cusp to get the implant angle.
What do I lay
Okay.
with you?
Certainly the root doesn't look that big, and I think that's kind of another checkpoint. We can decide whether 26 versus 29 has 3.
Okay.
Floor
Then
off a minute.
next.
Next slide.
George.
Okay, 1 second. Floor off. Okay.
Floor off.
So-
1 second.
So I'm
Okay, this is the
interested-
sentinel. So we routinely, as a final check, we do an arch angiogram because you can see here on the left carotid artery, it looks more tortuous than the CT scan. So this is the final checkpoint before we open the device. We also obviously do a right radial catheterization and engage with the wire as well. So this is now live on the sentinel protection device. George, you want to comment on the protection?
Keep going.
Yeah, actually, this is just a step to have a
Yeah.
300 run through wire exchange over for the other catheter we had, just to make sure the radial axis to the aorta is patent. Then the device is navigating, as you see, next loop. We'll open up the innominate filter, and then we're going to curve it up. And as you see, then the run through wire takes very nicely the curvature, as well as will allow the advancement of the other filter, as you see the final position here.
So
Yeah.
one
And,
point that I would like to make here is, I know we chose a run through, but often I think
Okay.
the wires that you need to be using here is a fielder 300 or many times Grand Slam. So depending on the final arch angiogram, you'll decide
Yeah.
which is the wire you want to try so that
That's
you will
right.
negotiate and navigate this
Now,
device
one
across.
second, what you see now in the fluoro, there's no go in the C. You see, we have a sequential engagement of the 3 cusps with a single pigtail in order to absolutely verify that this is a very good position for the alignment of the valve later on.
And George, how much time took you for the sentinel? Because that's always the question comes. That how much time it does add to the
Just-
procedure?
Just a couple of minutes
Yeah.
Beautiful.
for this case.
Fantastic.
Fluoro.
And we cross the valve using AR2, if you see there. And then I think another interesting point here is that even though you cross the valve with the AR2, always exchange to a pigtail, so that now we are going with a confida wire, and you will have the pigtail. See that you have to have this kind of a nice loop in the apex with a nice wire position before you even think of getting your valve
Absolutely true.
inside.
And we like to do this exchange in the area of view as well as with the BAV, and then we're going to go to the implantation view afterwards.
These are the minor key points we have to pay importance to.
Okay, great.
Okay, now then question is BAV or no BAV, and why BAV? Because knowing some data from Cedar Sinai recently showed that the valve tower without BAV had lower CVA rate compared to BAV.
Our initial plan was not to do BAV, but right now when we check the echo again, there is at least moderate calcium, moderate to severe
lot of
calcium,
calcium.
and I think what we felt is that pre-BAV probably is essential.
Good.
So-
We already
so
have
I-
a sentinel in place.
Right.
So as you guys are doing the
Now you can have
BAV, I do
discussion
want to
with the
have
panel,
some
yeah.
discussion
Yeah.
with the panel, please. We can watch you.
Absolutely.
You
Yes.
guys stay quiet so I can
Yeah.
talk to my
Beautiful.
panel. Thank you.
You're
So
gonna see
we
how the
have this
balloon goes
great,
through the
we have a great panel
sentinel.
here. So the big question, one, distal protection. One question. Are you using it when there is a good
Okay, guys.
thing, or are you choosing the patients, or are
don't
you
even need
feeling
to
that
pinch.
you should use it or not use it at all? In Europe, I know it's
Finish.
not even being used. So, Eberhard, what's your take on distal protection?
Well,
Off the pacer.
you know where my position is with just the
Yeah,
protection.
so, but-
I believe it's excellent. It's excellent that do we.
Can
we
we
can
take
hear
that?
you.
Okay, I think it's an excellent choice because since we don't know which patients are at risk, I think the better way is using it in all of them. We know why. It's been proven. I think this is a
You have
brilliant,
to go negative on
brilliant
the balloon.
proceed here for
Okay.
this particular patient.
Again.
The other thing that I would like to mention that Dr. Kini, said it's minor, but I think it's an important thing, that you
Negative.
exchange to a pigtail
Negative.
and
Yes.
Negative on the balloon.
don't try to skip that because this is when the perforations happen.
That's
I think
right.
it's a very, very important step. And the other thing is the choice of the valve, I think is a good one. At least from what I've seen on the CT, it's kind of a horizontal aorta. And I think a shorter valve, horizontal, is very well suited for an S3 much rather
Yes.
than for a core valve. I think
Very
it's a good
interesting.
choice.
So, and also the sizing. So, Antonio, as we're watching them doing the valvuloplasty.
Let me say one thing, your husband with a red cap, that is very, very interesting.
All right, good. Dr. Colombo.
Okay.
Yes.
Regarding distal protection,
What's
of
up with
course,
the red
if
color?
you can afford,
It's very
I
interesting.
believe you should
It's my
use
favorite
it,
color.
and you should use it all the time, unless you have a unfavorable anatomy. The choice of SAPIEN 3 is very appropriate. The size, I agree, 26, maybe with a couple of cc more. If you do a balloon valvuloplasty, you may take advantage of doing an aortic injection to
Yeah.
double check the appropriate size and confirm about the 2 or 3 cc more.
Dr. Usia, anything else
okay.
to add as far as the choice of the valve and how they're proceeding here?
No, I agree with the choice of use the embolic protection. About the valve, yes, maybe
Yeah, we can hear you.
yes, maybe I would use the 29.
You might use the 29.
yeah,
I think it's a kind of an interesting question. So let's see what happens. Take us through your balloon valvuloplasty now.
Okay, we're done with the valvuloplasty.
Yeah, good.
Wire.
It's an
Why does
advantage
come out?
of this valve that you can under and over, depending on
Mm-hmm.
the
Very quickly, at least we don't go in.
That's a good thing.
Good job, Asad.
that you can do.
Okay. Do I see that the wire is no longer in the LV?
Okay.
Yeah, we have to recross.
We'll have to
the
recross.
Yeah, that's okay.
So this
So
is
as
a-
you're talking, we're
this is
gonna,
a
as you're
point of
recrossing, I want
discussion.
to talk with Alex. Alex, do you like the choice of the valve? they-
Let's come
they
back to
chose,
our
or-
point.
I do, Roxanne, but I have to say that this case can be suitable for any valve. I
Right.
don't see a lot of calcium, so I think that even a self-expandable would do well. Not too much calcium in the outflow as well. So I think that this would be a good candidate for any valve. My question is that in patients with renal failure, in Mount Sinai, are you using any different imaging technique to avoid too much contrast?
Where is it?
Co-registration?
I can tell you that their contrast use on an average is no more than 40 to 50 cc's per case. They really are not using that much contrast, but and I think they use a lot of their prior imaging to avoid too much. Now for the
Hey,
course, maybe
we
it
should
would be
test the
different. But
patient
I think this
before we,
patient is an interesting
because-
one for us to kind of talk a lot through about all of the different issues that might come up. I think important to this particular case was the fact that there is coronary disease, and we saw
What you
that
give
they
me?
didn't
L1 you
treat the
give me?
coronary disease. And I always wonder, are we over-treating the
Real-
coronary disease in these patients
The
that we're
balloon
finding?
valvuloplasty got
As
stuck
you
on the-
saw,
on the
they
sheath,
did
on the
a
edge of the sheath.
dobutamine stress that didn't show any ischemia, so they're proceeding with the
Okay.
valve
We'll place a
without
piece of wire.
treating the coronary disease. What are you
Good.
doing? What's your
Here, try pacing now.
I
advanced.
agree, Roxanne. I think with
Oh,
this
it's-
elderly patient, you don't want to be super
It's
aggressive with
LAOV.
treating every single vessel.
Yeah.
What we do is generally, if you have a big, large epicardial vessel, we treat that perhaps culprit vessel and try not to do, the marginals
Too
and
much stuff, right?
yeah,
Exactly.
too much stuff. But when I treat patients with coronary disease
Patient is not at
and
the right spot.
TAVR, I do first the coronaries and then I go ahead with the TAVR. I
Yeah,
think
and
most
although
of
we're
us.
going to hear about an aid that Dr. Kinney has developed
Pacemaker,
to
you have to
deal with
inflate it.
with what to do in post-TAVR patients, and
balloon
I think
inflate the
it's going to be
pacemaker.
very interesting. Okay, where are you guys? We're catching up with you.
Yeah, we are
Well,
just
continue your
we are
discussion.
already here, but we are putting a pacemaker a little better.
Very interesting point that I want to make here is that we had not introduced the valve inside the body.
Yeah.
The question with the same, if we had introduced a valve inside the body and the wire has come out of the LV, it will be a issue that we cannot take the valve out
Right.
to get into the LV again.
Right, but I think
No,
what's
valve wire is good
nice is
position.
to
Why are
see
you
that,
doing it again?
this after the valvuloplasty, they lost, they were back, they were no longer across
No,
the
they-
valve, but they went back and didn't do any shortcuts. I think, again, it's important, even in a live relay, not to make any shortcuts, to keep your procedure as you do it all the time. You see they're
Is it pacing?
exchanging, I think, with a pigtail and then again with their wire. So it's taking a little bit longer, but that's
But
exactly
George,
what you
tell
need
us
to
why
do.
the wire came out so the audience understands. Yeah.
Okay, so the aspect of the wire coming back was somehow the entry of the balloon valvuloplasty was caught at the edge of the
Sheath.
of the big sheath, and needed quite a few manipulations in and out in order to unentangle it and pull it into the sheath, and that created a bouncing back of the wire at some point.
So what size balloon was that for the pre-dilatation or the valvuloplasty before?
20.
20 by
20.
4.
And how often are you guys skipping the valvuloplasty on the panel? Anyone is skipping it at all?
A lot. I do most of my TAVR with, for instance, with SAPIEN direct.
Directly.
Yes, for CMET for accurate. Most of the times I pre-dilate because of the lack of radial force.
Doctor?
Yeah, about the same. I would say where we do valvuloplasty almost always, so close to always, is with the accurate. But with the other valve, I would say
You are
20,
not doing that.
25%. Of course, depends on the amount of calcium. With a core valve, if you have a tight stenosis, it is better to do a valvuloplasty because when you stay there with the valve, you don't impair with the blood flow.
Okay, great.
Okay, now we are
I
ready
see
to
you're
go
all
in with
ready
the
now.
valve. I just want to show you an important point. The first person, which is going to be George Dangus, he's going to make sure the valve orientation is proper. Okay, you see here the skirt facing down. The
Yes, very
surgeon
good.
who
We
is
check
next
here.
to him
Yeah.
is going to confirm
Yeah.
the valve orientation is correct. And then with the loader cap, we will go
Are you
inside the
happy
body.
to confirm?
Yes.
Yes, confirmed.
Okay, fluoro, please. On fluoro the exchanges because of the sheath aorta relation.
This one. Bring it.
All right.
So this is going very small bites, slowly going inside. It will be tight initially, and later on as he goes up, you will see a give way.
Okay, let's take the view
Now
now.
we are in the
to
descending
a-
aorta.
You tested your
Let's get the view to
pacemaker
a
because I
PLLA
saw it had
AO.
come out and you
Yeah.
tested it, right? The pacemaker.
Yeah.
You will
Now,
test it. We'll
now
test again.
Roxana, on the
Okay.
panel, do you have Dr. Usia and Ravindra
Yes,
also?
Dr. Usia is here, of course. He's been talking.
Perfect. So we'll hear his comments also. Good.
So the
Okay.
next point is here, the second person, whoever is here, will be doing what is called as a valve alignment. Essentially, you're going to unlock.
Let's show this, please. Over here, the white.
Yeah.
So the person who is holding the wire is paying attention, holding the wire. So I'm going to pull this balloon back. As I'm pulling the balloon back, way into the valve. Lock here again. Then you have the fine adjustment wheel.
It's good.
Good.
Perfect.
Both happy.
Okay.
Okay. Unlock, lock. And now what I'm going to do is use a flex wheel as George is going to go across the arch.
We're going slowly. We're gonna be
And watch for the sentinel.
we're gonna be cognizant of the embolic protection device and of the wire.
Assad is paying attention to the wire all the time, holding it taut.
See,
Well,
it's
It's
passing.
so
without
nice,
see
you know, when you watch that. And in the
Beautiful,
trial also, we really saw very little communication between the distal embolic protection device and the aortic valve.
Yeah.
So, okay, talk
So I
us
was
through
fully
what you're
flexed. I'm
doing.
going to unflex the valve a little bit.
We're not crossing.
We cross.
Okay,
Yeah, we're
Yes.
crossing. We're
You're
across, guys, and
crossed?
we're in
Nice.
good position, in fact.
Okay, now what we are going to do is we got to bring the flex catheter behind so the balloon will be exposed. So I'm going to unlock again. Assad is going to pay attention to the wire. I'm going to bring the flex catheter back and leave it at the second mark. Lock again, and we are ready to test the valve.
All right, let's do it. Let's test it on the pacing. So we test the pacemaker as well. We pace on 150 and we do an injection.
180.
Okay.
Pace at 180.
Ready? Pace.
Not capture.
I told you, did you test
now.
the pacemaker?
Yeah, we did
Okay.
earlier, but now
Seen
it's
it?
okay, good.
Right?
Inject.
Yeah, always.
Fine.
Good, looks
Yeah.
Okay,
Beautiful.
now it's working.
Okay, very important. You can't have multiple people talking. So we decide the second
Let
person
this
always
finish
gives
it,
the
because the
command.
pacemaker moves. Please.
Good.
We don't need a person to be, have those things.
We are happy with the position?
Yes.
Okay, so take the pigtail out.
So you can see there's nice calcium landmark at the base of the non-conic cups where the balloon marker is, so we can make sure.
Okay. Pace 180.
No.
Okay, I'm going up and also warn anesthesia.
Let's go.
We do a slow
Inflate it.
inflation, very nice. 7 atmosphere.
Inflate it. Keep going.
And we look
all
at the
way, all
atmospheric
way,
gauge
all
here.
the
It's
way, all
Facing
the
off?
way, all the way.
7 atmosphere.
Off
No.
the pacer.
I told nobody gives multiple instructions.
Only one person can talk to
Yes.
Beautiful. Okay. Resuscitate, please.
So we now
Pressure is good.
we now center
80.
the wire.
Pressure is very good.
Okay.
Okay,
And,
very good.
and then we'll take. Let's have Stam have a look at the echo.
Excellent.
So you can see the 26S3 fits pretty well. If you go back to the aortogram, actually we'll look at echo first, and then we can look at compare.
His pacemaker completely off, please.
So
The wire.
great position. The function is as was before the valve deployment.
Let's get ready with the pigtail.
No AI, no valvular AI, no PVL,
Oh, great.
Can you show
No
short
peri-
axis quickly?
no pericardial effusion.
Yeah.
Beautiful.
Well, because of the underlying AFib here, it was a little bit, the blood pressure did not go up immediately with the second or third beat, but after like 10, 15 beats, it went right up. And we're in very good shape now with a heart rate of about 50 to 60.
Good.
The patient, by the way, has a wide right bundle in addition to the AFib to begin with.
Right.
So we have to watch what happens with that. And the baseline EKG.
Stam, we are good.
Okay.
Really good.
So you can see also we typically put the
Can you show
bottom
us
of the
the
balloon
fluoro? Yeah.
marker just at the annulus to
Let's go to fluoro.
to
And let's
implant a
take
little
our
bit more aortic.
equipment back, watch the wire, so we can exchange for a pigtail now in the LV. And let me watch again the sheet so we don't have the same issue again like before.
Very nice case.
So, Rox,
Yes.
what are they doing, Mount Sinai, after the implant? Are they only relying on echo,
something
or are
there.
they doing angiogram or hemodynamics, or what is it?
I think mostly on echo, but they
We-
always do the angiogram. They always do the hemodynamics. There's no shortcut, but I think you
for-
can just go on the echo, frankly. We have a wonderful
have the wire now.
Stam
But-
Larakis
but
has just joined us from Emory University. He's running all of he's the systems chief for imaging for Mount Sinai, and he's in almost every one of the cases with Dr. Kinney. and the team. So we feel very confident with the echo,
And
but
just to know, let
we
me just
still
answer
do the
that. No, let me
hemodynamics.
answer that question. No, let me just answer that. The many times we can skip the hemodynamic portion, but all cases getting echo and aortogram. Aortogram, we are doing it in everyone. I know we may not need to, but that is what been the practice. But many, hemodynamics, of course, we are doing it now for the live, but otherwise it looks good. There doesn't seems to be any issues in terms of diastolic pressure, and so we'll just go ahead and do the aortogram and done with it with the final echo.
Yeah.
Gilbert, you want to comment on the aortogram and
Yeah,
orientation
we'll
that
do
we are
that in a
working?
short while, but I think too also it's important that as the data has shown, you typically, if it's constant sedation, you want to show at least 2 out of 3 modalities for paravalvular leak. So either aortogram and echo, or echo and hemodynamics, at least 2 to be more reliable as TAVR goes to more minimally invasive approach. And I think also for smaller valves, like 23 millimeter leads, which you can know that the Howie Herman paper showed that's mismatch. We also do hemodynamics just to make sure there's no gradient across
3-0.
the valve after implantation.
Very good. So the hemodynamics right now as follows. The blood pressure is about 140 over 70, and the EDP is about 15. So
Good.
we're good.
So
We're
you'll
gonna do a
just do an
final,
aortogram,
final
yeah?
aortogram.
We'd like to see
we
if we
will do an
could, your
aortogram.
distal protection device, if you get anything out of that, it would be interesting.
Fluoro.
And
Fluoro.
we only have 2 minutes left.
So I have a question to George,
Yeah.
Roxanne. What's your protocol now, since you are the leaders and experts on anticoagulation and DAPT after TAVI, for a patient like that with atrial fibrillation? What would be your prescription when the patient leaves the hospital?
So George, this is
That's
your
a very
patient.
easy answer. We're going to enroll the patient to the envisaged trial because we really don't know the answer. And that's the proper way to do. As
Well, what
opposed
are
to
you
make
doing
up
in the
an answer
meantime?
that a few years later find out there is more. In the meantime, I'm enrolling the patient in envisage.
So
That's
the
all I'm doing.
otherwise,
envisage
yeah,
study,
but the
let me just
single-
make sure for
usually
those of
the
you who
no
don't
act-
know, is a study that's looking at the novel oral anticoagulant adoxaban in patients with
Beautiful.
atrial
Wow.
Very
fibrillation
nice.
undergoing
Oh, yeah.
TAVR
Beautiful
compared to
result.
Coumadin.
Very nice.
So here's the aortogram, looks gorgeous.
Yeah.
Access to the
Yeah.
coronaries
So
are
one thing
still
you can see,
good.
right, and you can see
Yeah.
here with the aortogram, we try to implant more like 80-20. That's kind of to minimize the pacemaker rate of implantation.
So, but the answer to the previous question was that the standard of care is the use of Coumadin.
Yeah.
Any other agent is off-label, and that's what we inform referring doctors and any other cardiologist. And therefore, otherwise, if no Coumadin, then the patient needs to be in the envisaged trial. Very clear and very simple.
And many of them actually the insurance does not allow. Even you want to use a no act, they
See if
don't
there's
approve
anything
it.
there.
That's right. And
Yeah.
in the trial, that's not an issue.
So we saw how
Well, I wanna
nice and
also
easily you
illustrate now-
removed the distal protection device. It would be nice, Dr. Kinney, if you show us if there's anything in there. Did you collect any debris?
We are looking.
Yeah, so while they do that, I want to show you at the time of implantation, we now try to crimp the SAPIEN free valve in a certain manner to make the TAVR coronary access friendly. You can see here in this particular view, this is the coplanar view, the double tap is the commissural tap. So actually, you can crimp the SAPIEN free valve in a certain manner to try to point the commissural tap away from the left main so that you can make it coronary
Nothing there.
access potentially friendlier.
Yep.
Well,
And
yeah, no,
particularly
that's
in
a
this
really
case, we
nice
require
point.
multiple PCIs.
Yes.
Yeah.
Yeah.
Multiple PCIs. Yes. Okay.
Roxanne,
With
may I
that
ask
note, I think we
to
have
George,
completed our.
if in this patient he
Transmission,
would
yeah.
consider to close the appendage because he had already
Yeah,
hemorrhagic
so it's a
failure.
really good, it's a very, very good question for this patient with a prior intracranial hemorrhage. Would you consider closing the left atrial appendage and not do any anticoagulation? Here's a patient who's had an event.
This is a great.
See you next one.
This is a great question. This is obviously an exceptional indication, but this discussion will be had exactly this coming week, and I think that will be very important for this patient because there was a concern of some
Nice job.
bleeding, even intracranial bleeding around the time of stroke in the past.
Right.
And particularly there is a trial ongoing to answer that question.